Hello, everyone. My name is Hamza Hashmi, and I am a physician at Memorial Sloan Kettering Cancer Center. In my research and practice, I focus on plasma cell disorders, where I see patients with multiple myeloma and AL amyloidosis. Today, I will be talking about supportive care in multiple myeloma. Today, we'll be discussing infection prevention, thrombosis prophylaxis, and bone health in patients with multiple myeloma. Infections can be commonly seen in patients with multiple myeloma, more so in patients who have relapsed myeloma, as well as patients who have newly diagnosed myeloma and are about to start their treatment journey. Traditional risk factors for infection in myeloma include advancing age, because as we age, we do see a decline in our immune health. It can also be related to the underlying immunosuppression that we typically see with multiple myeloma, as the plasma cells that make immunoglobulins are affected in patients who have this particular malignancy. Patients who received chemotherapy and immunotherapy for multiple myeloma can see a decline in their neutrophil count, in the function of their T cells, as well as low immunoglobulin levels by the virtue of the treatment that they are on. In fact, patients who undergo stem cell transplant can see significant damage to the mucosa that can lead to not only gastrointestinal infections, but also some bloodstream infection due to the chemotherapy. Men, as compared to women, tend to have a higher risk of infection, and certain medical conditions or comorbidities, like patients who have diminished renal function, liver function, or have a medical condition known as diabetes mellitus, can actually have a higher risk of developing infections as well. The four cornerstones of infection prevention in patients with myeloma include general hygiene measures, anti-infective prophylaxis, IVIG administration, and vaccinations. Moving on to the general hygiene measures, anytime we have a patient with multiple myeloma who has had CAR T or for that matter, a stem cell transplant in the preceding 3 months, we strongly advise them to actually wear a mask in crowded spaces. What are those crowded spaces? They typically include places where you can come in close proximity of other people who may be healthy or unhealthy around you. For instance, patients who may be exposed to other people at grocery stores, at bars, restaurants, churches, or in public transportation. We also recommend that you perform good hand hygiene and hand washing for at least 1 to 2 minutes, either with a soap or for that matter, a hand sanitizer. It's equally important for the caregivers and family members taking care of myeloma patients to practice these hygiene measures, including wear a mask in crowded places, as well as getting their age-appropriate vaccinations done as they are taking care of the myeloma patients. For instance, I would recommend my patients' family members and caregivers to undergo flu, RSV, as well as COVID vaccines on a regular basis if they are in close proximity of the patient. Moving on to anti-infective prophylaxis that primarily focuses on herpes zoster and pneumocystis prophylaxis, we usually recommend any myeloma patients who's on treatment with proteasome inhibitors like bortezomib, carfilzomib, CD38 antibodies like daratumumab or cetuximab, who have had a recent transplant or CAR T treatment received, or patients who actually are on bispecific antibodies to be on either acyclovir or valacyclovir for herpes zoster prophylaxis. Many of my patients would ask me that they have had chickenpox growing up, or they received Shingrix vaccine, and anytime they are on therapy with any of these agents, I still recommend that they go ahead and receive treatments with acyclovir or valacyclovir. The only time I recommend them to they are able to receive Shingrix vaccine is when they are at least 2 years out from their transplant or CAR T. They're at least 3 months out from their last treatment with daratumumab and bortezomib-based therapies. They have received Shingrix vaccine, and only after that they can discontinue their acyclovir. If a patient develops recurrent herpes while they're receiving treatment for myeloma, I do recommend to be on lifelong acyclovir or valacyclovir. The pneumocystis prophylaxis is typically recommended for patients who are on daily prednisone, 20 milligram or more for at least a month or longer. It's also recommended for patients who have had a transplant or a CAR T in the preceding 6 months. The typical choices include medicine like Bactrim, which we usually take as a single tablet every day, or double strength tablet 3 times a week. It can affect your blood counts, renal function. Patients can develop sulfur drug allergy to them. And in those circumstances, the recommendation is usually to use pentamidine, which can either be given as an inhalation or it can be used in the form of an intravenous treatment as well. For patients who are not able to receive any of the two, we do recommend atovaquone, which is usually a liquid medication that they can take and can have an unpleasant taste sometimes. And for patients, they also have an option of receiving dapsone. The only guidance here is that if you happen to be an African American individual, do make sure that you get testing for enzyme deficiencies that can provoke anemia if you're on this particular therapy for pneumocystis prophylaxis. Moving on to IVIG administration, International Myeloma Working Group recommends that any patients who are on bispecific antibodies like teclistamab and lenalidomide, talquetamab for relapsed myeloma and have an IgG level less than 400 should be receiving monthly IVIG. In my own practice, I usually recommend to all my patients to start IVIG as early as second month of their treatment. For patients with myeloma or any other chemo or immunotherapy who had an IgG level less than 400 and are experiencing recurrent sinus and lung infections, by which I mean at least one infection that puts you in a hospital requiring IV antibiotics, or 3 or more infections that require oral antibiotic treatment in the outpatient setting, should be considered for IVIG treatment to prevent future infections. Vaccines are mandatory and important for patients with compromised immune health with multiple myeloma. I usually recommend that all of my patients who have had received either transplant or CAR T to receive flu vaccine, RSV vaccine, and COVID vaccine 3 months after their procedure. I do recommend that they revaccinate for all childhood immunization starting 6 months after CAR T. We do recommend that live vaccine, especially measles, mumps, rubella vaccine, not to be given for at least 2 years after transplant or CAR T. Oftentimes, my patient asks me about pneumococcal vaccine, and what I really recommend them that if they have never had a pneumococcal vaccine or only received PCV13 vaccine, they should receive the pneumococcal vaccine, and the recommended one is PVC21. For patients who are not able to receive MMR vaccine against prevention for measles and are in a situation with measles outbreak in a close proximity with someone who has had measles, there is a recommendation to use IVIG as prophylaxis in those situations.